Hola, ¿qué tal? Buenos días. Vamos a seguir con el programa y para mí es un honor presentar al doctor Enrique Bargalló, que va a estar co-coordinando esta sesión. Y es un simposio muy interesante, es un simposio que se ha logrado obviamente a través del tiempo, pero con las alianzas estratégicas con las sociedades quirúrgicas de Estados Unidos y Europa. Este simposio que denominamos SMeO, SSO ESSO, va a tener pláticas y vamos a versar sobre cuál ha sido el impacto de la pandemia de COVID con la práctica quirúrgica oncológica, cómo nos hemos retrasado y todo, pero más que ir hacia atrás es más bien ir hacia el futuro y hacia esta nueva normalidad sobre cómo vamos a trabajar, cómo vamos a esperar y vamos a ganar la experiencia ya de los participantes. En esta mesa va a estar, y a quien doy la bienvenida, al doctor James Howie. El doctor James Howie es el actual presidente de la Society of Surgical Oncology y está en la Universidad de Iowa, College of Medicine en Iowa. Estará también representando como presidente electo de la European Society of Surgical Oncology el doctor Domenico De Ugo, el cual se encuentra en la Universidad Católica del Sacro Cuore, y en la Universidad Hospital Fundación de Roma, Italia. Al final vamos a tener una mesa redonda, y la mesa redonda y la mesa de discusión va a estar coordinada por el doctor Enrique Bargalló, que es del Instituto Nacional de Cancerología, el doctor Charles Walsh del MD Anderson Cancer Center, el propio presidente James Howie y el presidente electo, el doctor Douglas Tyler, que está
We will have Dr. Douglas Tyler, who is
de la Universidad de Texas Medical
of
Branch
the
en
University of Texas Medical Branch in
doctor
Galveston,
Domenico De Ugo.
and Dr.
Sin
Domenico
más,
De Ugo.
vamos a
Without
dar
further ado,
comienzo y vamos a la primera plática del doctor James Howie, cirugía oncológica durante y después de la pandemia COVID-19.
I want to thank you for this opportunity to speak at the Mexican Society of Oncology. I'll talk today about surgical oncology during and after the pandemic. My name is Jim Howe. I'm from the University of Iowa, and I'm also the president of the Society of Surgical Oncology. I have no conflicts of interest to disclose. So let's go over a little bit of a timeline for COVID-19. Back in January 9th, the WHO announced pneumonia cases in Wuhan, and then 2 weeks later, the first United States case was reported in Washington State. On the 31st of January, the WHO declared a global health emergency, and on February 2nd, the US issued a travel ban from China. The next day, US declared public health emergency. A week later, the WHO named the virus COVID-19. And then on March 9th, Italy went into lockdown. And at that time, US stocks took a dive, down 7%, and trading was halted. 2 days later, the WHO declared a pandemic, and the stock market went down by 30%. The following day, US cases exceeded 1,000. A day later, Trump declared a national emergency and a European travel ban. Now, the federal government at this time did not really take a leadership role in ordering people to stay at home or for businesses to close. So states decided to take it upon themselves. And on March 19th, California decided to declare a shutdown, followed by Illinois and New Jersey, and then New York a few days later. By April 7th, 43 different states had declared shutdown orders or stay-at-home orders, and 7 states, mostly with Republican governors, did not. Now, further timeline on COVID-19 in the United States included on March 26th, the Senate passing the CARES Act, which allowed for $2 trillion to be distributed to small businesses and to workers to help them get through this pandemic. 4 days later, hydroxychloroquine was authorized by the FDA. And then a few days later, the CMS introduced preventive measures for long-term care centers, such as screening of patients and visitors for temperatures and symptoms, severely restricting visitors and the use of protective equipment. On May 1st, the FDA granted emergency use of remdesivir, And then on May 15th, the White House and CMS introduced some gating criteria to reopen the economy. By the 28th of May, US death rates passed 100,000. We reached 2 million cases by June 10th, 3 million cases by July 8th, 4 million by July 23rd, 5 million by August 8th, and then 6 million by August 31st. We passed 200,000 deaths on September 22nd, and then October 2nd, our president tested positive for COVID-19. This just shows the number of cases in the United States from January through October, and you can see a big spike in cases occurring in March and then again in July. And right now we're currently at about 7.4 million cases of COVID-19. Now the deaths lagged a few weeks behind, and we're up to now to 209,000 deaths. We talked a little bit about the stock market, and right after and around the time the pandemic was declared, the stock market dropped by 30%. The Dow went from 29,000 down to about 20,000, but it's clawed its way back up to about 29,000 right now. Unemployment reached a high since the Depression of 14.7%. So as far as pandemics go, this pandemic has been quite significant, but if we compare it to the bubonic plague in the 1300s, which claimed 200 million lives, we're certainly doing better than that. Smallpox of 56 million lives in 1500s, or even the Spanish flu of 100 years ago, which claimed 40 to 50 million lives. Currently, we're at 1 million global deaths, which is quite a lot and really unprecedented, in the last 100 years. This shows the global numbers of COVID-19 cases from the Johns Hopkins website, and it shows that the global cases are 35 million with over 1 million deaths. Now, what happened in the United States since the introduction of the coronavirus with increasing numbers of cases in March? Well, the American College of Surgeons came out with a group of guidelines for triaging and managing elective cancer cases. And they basically divided centers into 3 different phases. One was if patients were not overrunning the hospital, there were just a few positive patients, and there were lots of resources like personal protection equipment and ventilators, and those places could continue to do surgery when patients were thought to have a survivorship of less than 3 months if it was delayed. Now, there are some places that had more cases of COVID-19, and here we're getting to more limited ventilator capacity. The hospital is starting to have a high trajectory of cases, and here significant triaging of cancer cases was necessary. And so patients who were not going to live for a few days without surgery maybe could be operated upon, but everybody else should wait. And then finally, there were some hospitals, especially like in New York City, Detroit, New Orleans, that were completely overrun by COVID cases. And there were really no additional resources to allocate to surgery unless patients were thought to be about to die without emergent surgery. So these were some kind of general guidelines that were put into place. And then after these came out, the Society of Surgical Oncology decided to try to do more in-depth triage guidelines for cancer cases. The assumption was that the number of cases was going to continue to increase in many different areas of the country, and there was going to be a need to triage cases due to the shortage of personal protective equipment, staff, the need to use ORs for additional ventilator overflow, and for distancing of patients. So what we did was we got together with our chairs and vice chairs of our disease site work groups, and the 8 different work groups are listed below. And we asked them to look over the cases that are in their specialty and to triage those patients into those patients who could wait or who might need more urgent surgery. An example of that is shown here for breast cancer, where patients who had just atypia or benign findings or needed reconstruction really could wait 3 months. In patients with DCIS, who might be estrogen receptor positive, they could be treated with tamoxifen, and they could wait because this is kind of a pre-invasive cancer. In those patients who are ER positive could potentially get endocrine therapy or chemotherapy, but those patients who are triple negative or HER2 positive should probably be triaged to earlier surgery. Patients who have had treatment, surgical treatment already, might need to defer chemotherapy for 4 to 8 weeks. And those patients with unusual tumors like angiosarcoma or Phloides tumors, or patients who progressed on neoadjuvant therapy, would need to have more urgent operations. In colorectal cancer, the idea was to defer surgery for all cases when there are polyps or otherwise early stage disease, and to operate on all patients who might be obstructed, perforated, or acutely transfusion dependent if you had the resources to do so. But in patients who could get neoadjuvant therapy without any adverse outcomes, those patients probably should be treated that way until the pandemic subsides. Now, around this time in New York City, Jeff Drebin at Memorial Sloan Kettering and his group really looked at how to triage cases in their institution. Now, again, they were in New York, where the city was being overrun with cases. Now, Memorial was a little different. It's a cancer hospital, but they really had to grapple with many different issues that were similar to what we've experienced. And that is, what cancer cases are truly elective? Most of these patients will have a bad outcome if you wait too long. What are the operating room safety challenges that affect the anesthesiologist and other staff, like the ability to wear N95 masks and not to be in the room during intubation or extubation? And what role should surgeon leadership play in operating room decision-making? And what are the patient care missions versus the societal obligations? So what they decided is that only essential cancer cases should be allowed to have surgery during this period. And if they can't wait 2 to 3 months, then they should have surgery. Some patients who needed palliative procedures should proceed with those operations. And then in true emergencies like perforated viscera, then they should also have surgery. But no elective cases were going to be performed. And these would be delayed until a later time when COVID was not such a big thing. Now, at the University of Iowa, we were not overrun with COVID cases, but we had the same pressure that we might be overrun at some point. Nobody knew what the future was going to hold. So on the 16th of March, we were asked to reschedule all our elective cases. And then on the 20th, we were told that we can only do essential surgeries. Now, essential is different from emergent, and essential is defined as those cases for which a delay will lead to a compromised patient outcome. And this is the case for most cancer cases, but not all. Now, after about 5 weeks of doing this, the hospital realized that we never were overrun with COVID cases, and the things that we had put into place has really kept the spread of the COVID virus, at least in the hospital, down to a minimum amount, and the hospital was losing money. So we were told that we could resume elective surgeries on the 27th of April. Now, to do this, we had to do several things. We had to do COVID testing in all patients before surgery. We had measures put in place to preserve personal protective equipment. We had a no visitor policy, and any employees or patients that came in were screened by temperature and for symptoms. Now, it wasn't too long after this where the White House and the Center for Medicare and Medicaid Services issued some guidance to how we could reopen the economy and hospitals again. Now, there are some White House gating criteria that came out around this time, and this again we published on May 6th, and they wanted to see a downward trajectory of either cases or influenza-like illness in those patients who couldn't be tested, and that hospitals were treating patients without crisis care, and that there were robust testing programs in place for at-risk healthcare workers. And they suggested that as we start reopening our surgeries, that they be done electively in outpatient setting where there's decreased risk of getting COVID-19. And then eventually, as we move to the second phase, you could do this both in inpatient and outpatient. And then by phase 3, you could have a full resumption of inpatient care. So these were some guidelines that we tried to make sense of in this paper for surgical oncologists. Meanwhile, the SSO put together several web-based resources. There were several papers written by our members. There are 7 listed here. The bottom 3 we've talked about already. And again, these were made available in one particular place, We also had resources for links to other organizations and to other important papers as they come out. So this would be an easy one-stop shopping for our members to find significant information on how to treat their patients. We also did a series of podcasts. We interviewed the head of the disease site work groups and talked specifically about the triage measures for those particular cancers of each of those 8 different disease sites. We also did some webinars. I interviewed surgeons at Chicago and Boston, New Orleans and Detroit, New York and San Francisco to see what they've learned from the pandemic. And they all had different challenges that could be helpful for other people to hear about. And also we did 2 webinars with fellows and young attendings. Finally, we provided links to different registries for both cancer and surgery where patients could find an easy way to access and enroll patients in these registries so we could learn more about how patients do with COVID-19. Now, there are several other important studies that came out that really helped us think about the surgical care of patients. One was an impact of patients with cancer, the so-called COVID-19 Cancer Consortium database paper, which looked at patients who had either a current or past history of cancer who were diagnosed with COVID. And they accrued 928 patients in both the United States and Canada between March 17th and April 16th. There were 121 or 13% of these patients actually died by May 7th. And this just shows some of the risk factors. It's probably too small for you to see, so I'll tell you what it showed. It showed that 30-day mortality was influenced by older age, male sex, smoking, greater than 2 comorbidities, a greater than 2 ECOG score, and whether you've been treated with azithromycin or hydrochloroquine, and whether you had active cancer. It was protected to live in the Midwest of the United States or Canada, and they concluded that the 30-day all-cause mortality was high in cancer patients. Another essay looked at clinical trials, and the FDA gave some guidelines on clinical trials, but there are a lot of things happening with COVID-19. A lot of patients couldn't come to the hospital. Drug deliveries were not as reliable. It was hard to do follow-up visits. And so clinical trials were severely affected by the virus. And so this particular essay talked about a few things. And one is the importance of really getting the most out of your clinical trials and to not use unvalidated surrogate endpoints and instead use overall survival and quality of life as the most important outcomes, and also not to waste time looking at Me Too drugs and things that would not have a clear path towards successful implementation if wherever possible. And also a plea to address relevant questions in oncology. Again, because of the limited ability to do trials in the COVID pandemic. Another interesting paper came out looking at disparities in outcomes in what's called a tale of 2 cities, but it was actually one city, it was New York. And they looked at the outcomes for Hispanic and Black patients versus whites and found that the adjusted death rate was nearly twice that in the minority population than it was in the white population. And depending on which borough you're from, it could be even higher than that. And one of the realities of this was that patients who are Hispanic or Black were more likely to work in blue-collar jobs and don't have the luxury of working from home, and they also had worse health insurance. So this put them at higher risk. And so this was an important study to kind of define the fact that there were disparities that we needed to kind of try to address. Another paper looked at mortality and pulmonary complications in patients who had surgery, and this was a great study that involved 235 hospitals from 24 different countries. And 26% of patients were diagnosed with COVID-19 before their operation, and 74% were diagnosed within 30 days of their operation. They had a large number of patients, 1,128. The vast majority were emergent surgeries versus elective in 294 patients. And the 30-day mortality was 24% and was slightly higher for cancer patients at 27%. 51% of patients had pulmonary complications, and in those patients, the mortality was even higher at 38% and accounted for 82% of all deaths. Age greater than 70, having cancer, being male, having emergency surgery, an ASA class of over 2 was associated with increased 30-day mortality. And finally, they concluded that you should consider postponing non-urgent procedures in patients with COVID-19 and promote non-operative management wherever possible. Another study looked at hypercoagulability of patients, which was again from New York at NYU itself. Between March 1st and April 17th, they had a staggering over 3,300 patients who were diagnosed with COVID-19. And out of the number, 533 or 16% had thrombotic events, of which 6% were venous, which were PEs or DVTs, and 11% were arterial, which involved ischemic strokes, myocardial infarction, or thromboembolism. These patients had high D-dimer levels, and if you were in the ICU, your thrombotic event rate was 29% versus only 11% if you're on the floor. And the all-cause mortality was 24.5% in these patients with COVID-19, but if you had a thrombotic event, it went up to 43%. So moving forward, where do we go from here? We're expecting a second wave of infection in the fall, and we may need to move towards triaging patients again. So where we stand right now was mentioned earlier. In the United States, we have about 7.4 million cases of patients that have been diagnosed with COVID-19, with 209,000 deaths. And here we see the numbers for Mexico, which is 761,000 with 79,000 deaths. This just shows the data for the last 2 weeks. And we see that my state of Iowa in yellow there is 279 cases per million. And you can see that the Midwest of the United States is having an uptick of cases. If we look at Mexico, we see less cases, but even the Distrito Federal of Mexico City has 118 cases per million in the last 2 weeks. And you can see that Baja California and Nuevo León are also fairly high in these numbers. So the next question is really, how do we get out of this pandemic? Well, we've learned several different things from our experience so far. One is that social distancing probably is a very helpful strategy. Wearing masks is important. And then widespread testing will allow you to identify those people in your community who have the disease so they can quarantine. In those patients who have been exposed, you can do contact tracing and try to reduce the number of new cases by finding people who come in contact with people. But I'd have to say in the United States, we have not done a very good job of this. And then finally, developing treatments for this disease. Antibody therapy, vaccines, and other means of supportive care are really the things that we need to focus on. This just shows a recent event in the White House Rose Garden, and this is an example of some of the things not to do. This is not using social distancing and not wearing masks, which ended up in our president being infected, as well as many of his, the people who were at this event. So what are the treatments that we have to look forward to? Well, one is antibody therapy, and the first of these would be convalescent plasma, where somebody gets an infusion of the plasma of somebody who's recovered from COVID-19, where presumably they've developed antibodies to the virus. And in the trials that have been done at the NIH, there are 2 randomized placebo-controlled trials ongoing that show that it may improve outcomes in severely ill and hospitalized patients, but the trials are still early and that conclusion is not ready to be made. Now, the president recently received an antibody called Regeneron, which is actually a 2 monoclonal antibody cocktail where the antibodies have been raised to the spike proteins of the coronavirus. And this has been tried in a 275 patient placebo-controlled trial and in patients who were asymptomatic or just moderately ill. And in those patients, if you were seropositive, you didn't get any benefit. But if you didn't have antibodies to coronavirus, then you did get some benefit in terms of the reduction in virus load and alleviating your symptoms more quickly. There's another antibody by Eli Lilly, which is similar, but it's only 1 antibody. And again, it seems to have a similar effect to the Regeneron product. So these are things that are on the horizon that have, may be helpful for the treatment of patients. Really, the thing that we're looking forward to are COVID-19 vaccines. And there are a lot of different types of vaccines that are out there, and most of them are still in clinical trials. One type of vaccine is the inactivated and live attenuated vaccines, and this is kind of similar to the annual flu vaccines that a lot of people get, where there's a virus that can't replicate, but still has the proteins that can help you mount an immune response. And there's a company called Sinovac who has one of these vaccines. There's also DNA vaccines, and Inovia has a trial that the FDA has put on hold with this particular vaccine. But this delivers a plasmid that contains DNA, which gets into the cell, makes RNA, and then is translated into protein, which again is usually for the spike protein, which hopefully you develop antibodies to. And finally, there's the RNA vaccines. And these are products made by Moderna and Pfizer, which are in big clinical trials with 30,000 and 44,000 individuals. And these deliver RNA into cells, which is then translated into spike protein, which people can develop an immune response to. So those are three of the types of vaccines. There are three others, though. One is to use an adenovirus or another virus, which has the gene for the spike protein or some other immunogenic protein in it, in an adenovirus that will not significantly replicate. So it'll make this protein in your cells, you'll develop antibodies to it, and there are several different vaccines right now from Johnson & Johnson, AstraZeneca, and University of Oxford collaboration, and CanSino, which is the Russian vaccine that's being used right now. Now, the Johnson & Johnson has a phase 3 trial with 60,000 patients, AstraZeneca, University of Oxford with 30,000 patients, and we should have the results from these studies hopefully early next year. There's another type of vaccine, which is where you make the virus-like particles and you just inject those, which you can develop antibodies to, or you can make those in a recombinant fashion, which again, you should generate antibodies to. And there are different companies that make those as well. So those are the vaccines, and there's a lot of hope for those. But one of the challenges with the vaccine is, will patients get side effects? When the swine flu vaccine was made, people got Guillain-Barré syndrome in the 1970s, and that led to some harm to patients. So we have to make sure these vaccines are safe. We have to make sure that people can generate antibodies and that they will protect people from disease. And then if the trials look successful, we have to be able to make a large amount of these vaccines so we can supply countries and the whole world. What about other therapies? Well, recently, President Trump was also treated with a drug called remdesivir. Remdesivir is an inhibitor of viral RNA-dependent polymerase. And there was a randomized trial of this versus placebo in patients with respiratory infections and COVID-19. And this just shows that patients who had remdesivir had an improved recovery time that came down from 15 days with placebo down to 10 days with the remdesivir treatment. Mortality rate also decreased from 6.9% to 6.9% from 11.9%. So it does have appear to have promise for the active treatment of patients with respiratory symptoms. Another drug that President Trump got was dexamethasone. Dexamethasone is a glucocorticoid that attempts to modulate inflammation-mediated lung injury. And this was given in an oral or an IV form in hospitalized patients with COVID-19 in an open label trial to 2,104 patients who got the dexamethasone versus 4,300 patients who just got the usual care. Now, they weren't randomized, it's open label. Now, the death rate was modestly improved with dexamethasone from 23% versus 26%. And this is shown in figure A down here, but in mechanically ventilated patients, there was a much bigger change in the death rate from 41% down to 29%. So it looks like in really sick patients that dexamethasone may be really helpful. Well, what about after the pandemic? Well, I don't really have time to talk about things after the pandemic. I don't know what they're going to look like. I can tell you that this pandemic has put severe strain on the healthcare systems and the economies of most countries, resulted in many changes in how we teach our children, how do we educate one another. And I really think that things will be much better a year from now, but I really am not sure what things will look like in the near term. With that, I'd like to end and thank you from the Society of Surgical Oncology for having me speak today at your conference.
Excelente plática. Vamos ahora a la parte o la contraparte, más bien el punto de vista o cómo lo vivieron en Europa. Y para ello, el doctor Domenico de Hugo, presidente electo de la European Society of Surgical Oncology, nos va a hablar sobre cirugía oncológica durante y después de la pandemia desde la perspectiva europea.
Good afternoon, my dear friends and colleagues from Mexico. First of all, let me express my most profound thanks for the kind invitation and the opportunity to present to you our point of view as surgical oncologists in Europe in such a dreadful pandemic moments. Why an Italian speaks about this? You know that when the pandemic started out as a burst in China, Italy was among the very first country to be infected. And Italy, and especially the northern regions of Italy, were a sort of a laboratory where we experienced the worst of being hit by a pandemic that nobody was expecting in that proportions. So on March 11th, Italy entered a complete national lockdown. And as you see from the curves that are indicating the rate of infection among tested patients, we were able to control the pandemic with a very unhealthy, from the economic point of view, lockdown that was terrible for our firms, for our factories, for our schools, but the pandemic was controlled. Then something is happening again. Somebody calls it a second wave. It is not a second wave. We were never been one day without the virus. It is a scarce control of the opportunities that we have had, learning from the lessons from the recent past. And this is what's happening right now all over the world. This is the global cases burden as of today. And you see here the continuous increase of the number of cases that are reported worldwide, with a distinction from country to country, with the United States leading this terrible series. Here, I wanted to report the incidence of the continuous number of cases that are counted in Mexico compared to what is happening in different European countries that are different by culture and organization and health system. And so, as you see here, who is leading the negative, numbers is Spain, followed by the United Kingdom, for different kind of reason that maybe we can comment later on, then Italy and Germany that are observing a second slow but continuous rise of these pandemic numbers. And this is what is happening in terms of total cases worldwide. So unfortunately, Americas are the most hit in terms of number. Europe apparently is not among the worst of the situations, but 7 million is always 7 million people in a well-developed area that should not observe something like that, especially when we had, again, I say, lessons from the past that should have been learned. And in detail, what you have seen before, this is what happens in Spain, France, Italy, and UK. Please look at here, because the numbers are not the same proportion. So this is the level of 30,000. This is the level of 40,000 of positive diagnoses contemporarily done in one day. This is 20,000 in the UK and 6,000 in Italy. That still for us is not a good news, since we had the opportunity of observing a quasi-total control of the pandemic numbers during the summer. So this is what should happen when you know that a pandemic is coming. And this is what the health organizations, and especially the surgical health organization, and in our case, the surgical oncology service of a country should do, knowing that a pandemic is coming. So we have information that are good enough in order to create hub-and-spoke models and protect some specific hospitals, tailor levels of influence for emergency trauma and essential elective surgery, and then observe a recovery plan growing in numbers if some numbers have decreased in this phase. But unfortunately, what happened was this. We were hit at the beginning, especially in the northern Italian regions, by the pandemic. We had no information at all about the severity of the situation. So we experienced a moment where these essential services could not be provided to all. It was not only a humanitarian disaster, it was a health system disaster, considering that we could not give to all who needed emergency service and oncological services. This was extracted from a publication that came out from a so-called COVID surge collaborative group. And this group is getting information and quality control data from young doctors coming from practically all over the world. And especially from the Western world, they have collected data and numbers in order to count how many elective surgery were canceled because of the pandemic phase, of the worst pandemic phase. And you see that we can calculate that we had in this series that have been reported in this paper, a high rate of cancellation for colorectal, gynecological, head and neck, surgical, plastic surgery, upper GI, urology. Every single unit in collective numbers experienced a drastic cut-off of the number of surgeries that were expected to be performed during the same days. And this is what the Italian Society of Surgical Oncology produced as a consensus that was extracted from the experience of the northern Italian hospitals that were hit by the pandemic just after the hot phase. So there are recommendations coming from this surgical oncology society that I had the honor to be president some years ago, telling that we have to divide the periods of activity in emergency, high-level alert, medium-level alert, low-level alert periods, and this can imply that in these emergency moments there is an unavoidable cut-off of operations. So the resources should be in a plastical project reassigned dependent upon the level of intensity that is requested to hospitals from zone to zone and from time to time according to the intensity of the pandemic phase. That is very changing from area to area. What you have seen before were numbers taken from national data registries, but inside the same nation there are hot zones, orange zones and white zones. So the system should be trained in order to adapt rapidly and respond with immediate recollection of the lost cases in the second phase of the epidemic, or serve as a buffer in the moments where the closest regions are facing an emergency and the other regions are not. So this is another publication that was recently published on the Annals of Surgery, telling us that there is a terrible rate of decrease overall of emergency surgical oncology. And this is data that were registered before the pandemic, during the emergency phase, during the heat, and then this is data that were registered during the last week of data collection, that is at the end of the pandemic. So what you can see here, this is the information coming out from this graph, is that even after the hot phase, the possibility of the system to go back to the previous number, to reinstitute to people the number of surgeries that they need, is not so easy. There is a long phase of recovery because there is a doubled burden of cases that were the ones that continues to arrive month by month, plus the ones that have been postponed during the hot phases. So it's going to be a long time for paying the price. And you can see also the variation of the interval at different level of disease, HPV, colorectal, upper GI. And these graphs represent the number of operations that were postponed beyond what is expected after a multidisciplinary team meeting. So when an HPV meeting decides that there is the time to operate on a colorectal met, and this is expected to be done not later than 3 to 4 weeks, this is the enormous increase of the cases that are operated with a delay. And this is affecting all fields of surgical oncology, as you see here. These are not impression, these are not opinion, these are data. And this is going to happen to any country if we are not prepared to face at an organizational level the oncologic need of our patient. We have to remember that these delays will be counted in some years as number of deaths, because we are having for the lockdown more, we are observing late diagnosis at a higher rate. We are delaying surgery, so operating patient that can become not resectable anymore in a few weeks. This will be translated in a higher number of cancer deaths. And cancer deaths 5 years from now will be counted in numbers, most probably in a higher rate than the deaths that in this year we are observing by COVID. So we should take our attention high on this terrible infectious disease, but we should never forget that our task today is curing cancer and to decrease the deaths by a terrible disease that by 2030 will be the first cause of death worldwide, more than cardiovascular, more than infectious disease. Of course, we are not the same. Europe is a strange confederation of states, and any national surgical oncological association has wrote down its recommendation. They have most things in common, of course, protection of the operators and prioritization and organization in the waiting list, and the swab before and after the hospital admission are common in all these recommendations. Every single state in Europe has formed a committee of experts that are counseling the government. The government is getting these advices and transforming it in political orders or recommendation. And I must say that this is not always transferred exactly as the technicians, the doctors, and the committees have underlined and stressed to the politicians. So this is what the European Society of Surgical Oncology has written on its website in terms of advice for surgical oncology during this pandemic. And there are specifications as regards referrals to clinic, outpatient visits, treatments in hospital, general recommendation and recovery plan. Of course, every society has done it, but something is not working. And I will spend 2 words about this at the end of my presentation. This is another interesting report that was recently published, again, by the COVID Surge Cancer Cooperative Group. And I am so happy to be part of it in sending to this organization the data coming from Italy and Europe. And this is what happens when the recommendations are followed or not. So this is what happens in terms of surgical oncological treatment in patients that are admitted in hospitals that have been kept free from COVID and that are kept free as a single structure, or are kept free because they obey to all the necessary recommendations regarding the admission swab, regarding the pathways inside the hospital, and regarding the double control of the personnel. And this is what happens in different organizations when part of all these recommendations that are aiming to preserve COVID-free pathways are not maintained. It is obvious on an evidence-based data situation that pulmonary complication rates were always lower when patients were treated in COVID-free environments. And also the post-op COVID infection rate was lower in patients that had a first negative swab at admission and a second swab at discharge. So preserving wide pathways or wide hospitals for treating cancer is the very first recommendation. The second recommendation is that any patient should be tested before being admitted. We have to keep this environment safe. And this is what was observed at the beginning, when in Italy we have already learned the lesson of March, but the rest of the world was not applying the admission swab unless in 16.6% of the cases that were admitted. Only 6% underwent a CT scan in order to early diagnose possibly pulmonary foci of pneumonitis by COVID, and only 3.7% of the hospital did both of the tests plus a test at the discharge. Of course, this is changing. But at the beginning, the rate of this simple, organizationally difficult, but simple maneuver was ignored in the vast majority of the cases. Now this is changing, of course, because the numbers all over the world are rising. And now, as you see here, the rate of swabs at admission is continuously rising. But still, this is something that we cannot forget. So testing is the second message after the first one, that is maintaining wide hospital COVID-free at the maximum that we can, especially for socially interesting disease, that is the cardiovascular circuit, the cancer circuit, and the neuro disease pathway. This is a third publication that we have issued regarding the cooperative group, COVID Surge Cancer Cooperative Group. And this is a research letter entitled Delaying Surgery for Patients with a Previous Infection. What happens to patients that are tested positive and because of that need to be postponed after surgery? This is interesting because, as you see here, if you postpone for a very limited amount of time, the potential hazard to have pulmonary complication is much higher. So this is a little bit in contrast to the message before that was trying to maintain at best the surgical production and COVID-free areas. But when a patient that is plan in order to undergo a very important oncological surgical operation, and it is found positive at the admission swab, it becomes very important, delay as a delay, to wait as much as we need, as much it is possible in order to preserve the cleanliness of the hospital from the COVID infection and to preserve the patient himself from developing pulmonary complication, because the general state of the lung tissue is left by this dreadful virus always not in good conditions. So again, we have translated it in strong recommendation coming from the Italian experience and sent to the European Journal of Surgical Oncology in order to express our worries to our politicians that should transfer these into operative guidelines. And we know where this infection rate now is majorly expanding, and the first places at all that are at the beginning of the list are the nursery homes where the elderly live, and they have a high rate of infection, high rate of positivity, and they also represent the foci where the virus is sleeping and spreading all around. Then the family, much more than the hospital, is a place for not observing the social distancing recommendation and the mask wearing. And the families now are at the second place in terms of the location of the clusters that we observe, and then so on. As you see here, these recommendations are sent to politicians, and we are very active also in webinar where we invite not only our colleagues, but also our political representative in order to understand our strong wariness and our strong recommendation. But as you see here, doctors are not happy. No, not all of what we say, and nothing is against humanity, is applied by the politician. And I am not taking any position in the next major political event in the United States. But for sure, the fact that in the first time in the history, all the editors together in the most highly ranked medical journal in the world write down very clearly that the magnitude of this failure in listening to the doctors is astonishing, is something that I must underline and stress to all of you. We have to raise our voice and pretend that who is in charge of making decisions will assume the responsibility of being a defender of the humanitarian rights, not only for the bad choices that are spreading the virus, but also for the rights of our patients that are dying for cancer if we don't obey to these elementary rules. Most of these debates will be also discussed during the next virtual meeting of ESSO that is going to take place on Friday, October the 23rd, at a timetable that is good for the Americas. And on Saturday, we will replicate most of these debates, like the presentation that I have expressed to you today with honor, will be at a time that is good for colleagues listening from China, Japan, and Korea. So I hope that I have not been confusing you with numbers and I've not rushing too much. And again, as a surgical oncology caring for humanity and cancer patient, I profoundly express my thanks to the Ecological Medical Society of Mexico for the kindness and sensibility to have me among the presenters of this wonderful virtual meeting. Thank you again.
Vamos a hacer la sesión de preguntas con nuestros invitados, el doctor Douglas Tyler, el doctor James Howie y el doctor Charles Valls, y para eso dejo la coordinación al doctor Enrique Bargalló.
Pues, antes que nada, thank you very much, all our friends and colleagues there in the United States. Dr. Howley, Dr. Taylor, Dr. Balch, friends of us, thank you so much for being here and talk about these new approaches in the surgical field in a pandemic era. So even in a virtual or hybrid symposium, thank you so much for being on live. So actually, my first question is, what have we learned that without pandemic we should encourage all our surgical oncology friends, colleagues to do for the rest of our practice? I mean, like, do we need to change this kind of saving resources? Do we need to
el tipo de
forget about it?
recursos, tenemos
Which
que
are
olvidarnos
the main lessons that
de
do you
todo.
think that we learned for the, not next year because we're going to be on pandemic for through, but for the next 5 years?
I'll take a shot at it first. I think there have been some good things that have come out of the pandemic. I think, first of all, the connectivity through virtual tumor boards, telemedicine, have, I think, expanded the reach of an ability to have consultations and connect with patients who can't generally come to the hospital. I think it's also started to teach us a little bit about how to be more conservative with medical resources, especially protective wear and other things for the healthcare workers as well as for patients. And I think those are here to stay. And then I think just some of the infection control processes that we've put in place, hand washing, wearing masks, those actually probably have some extended benefit to other diseases, that I think prior to the pandemic, people were usually less frequently washing their hands or using good sanitary techniques, when moving from patient to patient. So I do think there are some things that will continue to last beyond the pandemic. I think how we manage the rest of our practice will depend on many of the things that Dr. Howe elucidated in terms of how prevalent the virus is in your community, what is the current proportion of hospitalizations, both in med-surg beds as well as the ICU, that are occupied by COVID positive patients, what's the test positivity rate. Those are kind of the things that help us understand how much of our resources need to be focused on the infection versus the rest of our practice. And I suspect different locations will have different surges or peaks at different times. And I think we saw that with some of Jim's talk as well.
I'll make one brief comment that I think we're going to enter into a new era of antivirals. This has stimulated scientists all over the world to study viruses, vaccines, antivirals, and so forth. So probably a benefit that will accrue over the next few years is a broader number of antivirals and management of patients with viral illnesses that will benefit societies around the world.
Quiero mencionarles a los que nos están escuchando que pueden mandar sus preguntas
vía el chat y aquí las vamos a poner. Entonces, nada más les recuerdo que por el vía chat pueden mandar las preguntas para poder tener más interacción con nuestros ponentes. ¿Una otra pregunta para ustedes? El día de ayer tuvimos la presencia del Premio Nobel 2018 hablando de inmunooncología. Hoy estamos enfrente de un virus, hoy estamos hablando de vacunas. quisiera saber cuál es la perspectiva de los tres de la inmunooncología en la parte quirúrgica. La vamos a llevar al quirófano, el cirujano oncólogo cada vez va a tener que entrar más a hacer de alguna forma clinical trials quirúrgicos, prequirúrgicos. ¿Cuál es la visión que hoy tienen, siendo que tenemos recientemente y nosotros en nuestro congreso el día de ayer tuvimos la presencia del premio Nobel hablando de inmunooncología, pero desde el punto de vista quirúrgico, ¿cuál es la perspectiva de cada uno de ustedes?
I'll answer to begin with, and we can hear from Doug and Charlie, but I think that surgery is going to continue to have an important place for cancer. I mean, it's our best chance for cure. Our medical oncology therapies have gotten much better, especially immunotherapy for melanoma and certain other diseases, but surgery is still an important part of the treatment of patients. And just like we don't want to do surgery in COVID positive patients, medical oncologists don't want to give chemotherapy to them either. So, you know, if your hospital has COVID-19 under control and you have personal protective equipment and you can test patients and to make sure that you can keep your infection rates low, you know, I think surgery will continue to have an important role. As I mentioned in my talk, we weren't really that affected by it. We were really worried that our hospital would be overrun, but it never was. And that allowed us to really continue to do cancer cases even through that period of time where we were only allowed to do essential cases. Certain cases were not done during that time that could wait. But in New York City, for example, during March, they couldn't do any cases unless they were emergent. So as long as we can keep the viral infection rates low and keep our hospitals from being overrun with patients, surgery will still be a very important part of treatment.
Yeah, I would agree with Jim, and I think being in the greater Houston area, we had 2 periods of time since March where we had elective surgery bans because of challenges managing the virus. The first one early in the pandemic was related to lack of protective equipment for healthcare workers and for patients. And so we had to conserve during that time period. And the second one more recently was related to a spike in August of cases where our ICUs were being flooded with individuals with COVID positive disease. But as we've managed those, we've been able to titrate which patients should be prioritized when resources are limited. And I think there have been some very good guidelines that Jim highlighted from a number of organizations, one of which is the Society of Surgical Oncology, which highlight which patients can wait, early stage patients generally. And we're also learning through some of the registries which patients with more advanced disease might be able to be treated neoadjuvantly, not necessarily with chemotherapies that might lower white counts, which seems to be a low white count seems to be a risk factor for bad COVID outcomes, but also targeted therapies and immunotherapies patients seem to tolerate that and aren't associated necessarily with worse COVID positive outcomes. So you're able to potentially take some of these more advanced patients and instead of operating on them, urgently, you can, delay some of their surgery until a time when your resources are better. So there's going to be, I think, continue for the next couple of years, this balance between what are the resources, how do you have to prioritize patients that need surgery. I don't think the virus is going to change our mindset as much of who gets surgery and who doesn't, but I do think it is going to sort of demonstrate that some patients you can wait for a while. And that you don't have to rush them into surgery within 2 to 4 weeks and that their outcomes aren't any worse.
I would add to this that we need to have good communication with our patients. I've had circumstances where patients who were in a follow-up after their cancer treatment and were developing symptoms of recurrence, but thought that it was not okay to go see their doctor because of the COVID infection. And we may need to be even more proactive with our patients, especially those at risk and who are at follow-up or are delaying their treatment to communicate with them and coordinate the timing that is appropriate for them. So we can decide which ones it's safe to wait and those that really need care and need to come in, but may be hesitant even to call their doctor because of fear.
Somos parte de, y este es un gran ejemplo del intercambio académico y entender prácticamente que empezamos a compartir muchísima información a nuestros colegas y a nuestros residentes y a nuestros fellows. Estamos acostumbrados desde el punto de vista quirúrgico a hacer pases de visita con muchas personas. ¿Cuál es la visión que tienen ustedes ahorita, no nada más para operar un paciente, sino en esta interlocución que hemos tenido mano a mano con nuestros residentes, con estudiantes? ¿Creen que debe ser ahora más virtual o seguimos haciéndolo presenciales con grupos más pequeños? Cada uno de ustedes son profesores y son sin duda, tocan el corazón justamente a las siguientes generaciones. Y probablemente cómo nos reconvertimos, no nada más en la cirugía, sino en el pase de visita y revisando al paciente. ¿Creen que debe ser ya menos?
You know, I think we should see patients really the same amount. At our hospital, we all wear masks and face shields, and we wash our hands very frequently anytime we touch any inanimate objects or doors or patients. And, you know, all the conferences have gone to online, so that's helped reduce having larger groups. But, you know, everybody who comes in the hospital is screened for temperatures, by thermal monitoring and for symptoms. And with readily available testing for all surgical patients, you know, we try to make sure that we don't admit anybody with COVID. So I think we've been able to keep our numbers in the hospital down very successfully with that strategy. Meanwhile, in the city of Iowa City, with the university coming back online a few weeks ago, there was a huge spike in cases, but those patients quarantined themselves in dormitories and they didn't actually come into the hospital. So the fact of the matter is, even with the spike in cases, as long as the hospital is not overrun and you have a testing process in place and people are wearing masks and washing their hands frequently, I think we can continue to teach patients, teach residents, you know, on rounds and in clinic without a lot of restriction, but we just need to keep these testing parameters in place.
Yeah, I would agree. I think a lot of this revolves around what is the testing capabilities of your facility. Where I'm in Houston, everyone that's admitted to the hospital is tested. Anyone that comes in for a surgical procedure has to have a COVID test within 3 days. And people have to, when they show up to work, they have to sign an attestation saying that they don't have any symptoms. So we are pretty good at segregating from a patient point of view, those that have disease and those that don't. And the turnaround on our testing, we tend to be a center that has a lot of testing and actually do a fair amount of testing for other facilities in the greater Houston market. So our turnaround for a test is under 8 hours, and frequently it's within 2 hours. So we're able to better understand who's potentially at risk and who isn't. For patients who are screened and aren't at risk, we have our normal rounds. We do, you know, examine them the same way we did before, obviously with protective wear and stuff. For those that are COVID positive or under screening for COVID disease, they're in special units. You have to have extra layers of protective wear. You have to have a buddy system when you go in to examine them so that you can be observed to make sure you're not potentially contaminating things. And in the OR, if we have to emergently operate on somebody who is COVID positive, and to Jim's point earlier, there's very good data that we, you know, if at all possible, you do not want to operate electively on someone that is COVID positive. They have worse outcomes. but there's going to be occasionally some emergency procedure that needs to be done on them. We have a separate operating room, for them, that once the case is done, the room is decontaminated. And for a while, when we were having more COVID positive patients, we actually had a specialized COVID teams that focused on managing those patients. So, we didn't necessarily want a very junior person intubating somebody who's COVID positive, and fumbling around and taking longer. And we had teams that were very well trained to manage these patients. And we have that same sort of philosophy around our ICUs and our med-surg beds, that we have teams that are experienced. They usually work for a week at a time in shifts, and then they're given like a week off for rest, and then we bring a new team back on and circulate through. Now our numbers of patients in the hospital are much fewer, so we've sort of moved away from the content.
I would add that we need to be very sensitive to our staff and our trainees who are with us, that many of them may have a lot of fear and anxiety because they may be taking the virus back home where they have children or other family members or older members with comorbidities. And we just need to be very proactive in good communication and sensitivity to that fear and anxiety that our staff and those around us may have as we're delivering care, and their concerns whether they would either bring it to us or in reverse, take it back home to their family.
Héctor, otra parte del mundo, México. Tú y yo fuimos testigos de lo que sucedía justamente tanto en el hospital donde trabajamos como en el hospital, cada uno en un hospital privado donde trabajamos, pero también tuvimos contacto con otros lugares. Compártenos, tú cómo viviste la pandemia desde el punto de vista de cirugía oncológica, incluso encargado en una enfermedad como melanoma y sarcomas, en donde si el cáncer no espera, en esa patología específicamente, menos espera el tratamiento quirúrgico.
Creo que parte de lo más importante fue nosotros aprendíamos, conforme venía la pandemia, ¿no? Estábamos hablando de febrero, marzo, y transmitimos, de hecho, el mensaje a los pacientes de no vengan, no regrésense a sus casas, a menos de que sea una urgencia. Y creo que ahora, pasados ya 7, 8 meses de esta pandemia, vamos a empezar a ver ciertos costos de ello. Creo que en un momento dado, creo que sí exageramos un poco el mensaje al inicio. Obviamente no conocíamos el impacto que iba a tener la pandemia ni la longevidad que iba a tener, ¿no? El punto es que ahora, a esta nueva normalidad, creo que ya tenemos que sí tener cuidado, tener todas estas restricciones, pero sí tener que ya incidir en los pacientes, que aunque no es una urgencia, que aunque no sea algo delicado en este momento, dejarlo esperar lo va a convertir en una urgencia y lo va a convertir. Entonces, mucho en México, y sucede en todo el mundo, hay un exceso de mortalidad que no está registrado. Y suponemos que mucha de esa mortalidad va a estar dada por pacientes COVID que no fueron diagnosticados a tiempo. Los porcentajes varían de país en país, pero mucho de esa mortalidad o ese exceso de mortalidad son las otras enfermedades que no atendimos durante la pandemia. Es decir, mandamos a los pacientes con cáncer, muchos se autoexiliaron en sus casas y hubo mortalidad por cáncer, hubo mortalidad cardiovascular que no acudieran a los hospitales, y entonces todo ese exceso de mortalidad es lo que vamos a empezar a ver ahora. Creo que en esta nueva normalidad debemos ya regresar al pasado y decirles a nuestros pacientes con sospecha, con diagnóstico temprano o diagnóstico avanzado de cáncer, que tienen que regresar a los centros hospitalarios, y a los hospitales y médicos nos tocará hacer todas las medidas restrictivas para poder seguir conteniendo la pandemia.
Para los cuatro, Héctor, Charles, Dr. Howie, Dr. Taylor, ahora más que nunca, la cooperación entre sociedades creo que ha mostrado no solo una relación académica, sino ahora mucho más en compartir, mucho más en estar presentes, mucho más en la rapidez en donde estamos compartiendo, y este es un gran ejemplo en eso, hacia dónde vamos en el fortalecimiento a nivel totalmente global. Tuvimos una reunión hace unos meses con el doctor Howie y todos los líderes de las diferentes sociedades oncológicas de todo el mundo. Hoy es imperativo que esas sociedades de cirugía oncológica cada vez estén más unidas. ¿Cuáles creen ustedes que deben de ser los siguientes pasos para cada vez hacer más alianzas?
Well, I think the Global Cancer Forum is a really good way where we have interchange between ourselves, the European Society, Mexico, Brazil, Korea, Japan, China, India, and all of these groups with good communication. I think that one of the nice things about the pandemic, if there's anything nice, is the ability to communicate with each other online like we're doing right now. So we can go to each other's meetings without having to fly to another country. And that, makes information more accessible to people. And I completely agree with the point earlier that, patients were afraid to come to clinic and that we might see them in more advanced stages. And I think the message is important to have them come back. But I do think that being connected through the internet is really a great way to share information and to share initiatives. Certainly in those global cancer registries that people are accruing patients to, we're learning a huge amount. We've learned a huge amount from our European colleagues. I look forward to hearing, from more from Mexico too, and how you guys have dealt with the pandemic. Doug and Charles, your thoughts?
Yeah, I agree. I think the virtual acceptance now of interacting and communicating has really brought a lot of groups closer together. I think the pandemic has sort of made us realize no group is immune from the virus, and that we do have to work together. And to Jim's point, the creation of these registries and groups working together to try to identify what's a safe practice and what isn't. And sometimes we learn stuff that goes against conventional wisdom. I'd argue that actually increasingly it is safe to wait and not rush some cancer patients off to the operating room, especially for some of the early stage disease. If you look at the peaks of these pandemics, you're not telling somebody to go away for 6 months or a year. Normally the surges, when people recognize them and put in the proper controls, are usually back to baseline within about 4 to 6 weeks. So most of the studies that are starting to come out now suggest a 2-month delay in the treatment of a cancer probably for the vast majority is not a make or break kind of thing. Where I think that the bigger challenge will be is some of the screening, because their patients are generally asymptomatic. They don't know they have a problem, and they're going to stay away from potentially the healthcare system for a year or two. So something that might be pre-malignant or very early stage may be more likely to progress to an advance. And that's the group that they're most predicting is going to lead to the increased cases down the road.
I would just add very briefly that with our increased collaborations educationally through these forums, such as the SMeO meeting, that we should cooperate even more than we have in the past in participating in clinical trials and registries so that we can learn at the same time all over the world. As Dr. Howe said in his talk, that there was an increased risk in the New York City area among Hispanics, for example, and whether or not that's because of something unique to New York and our patient care delivery, or whether there's something more innate to inherited immune resistance to viruses. We need to understand risk, both inherited risk and risk due to our patient care delivery system, and then learn together systematically and prospectively through clinical trials as new agents, especially antiviral agents, are used in conjunction in our surgical patients.
Gracias. Tenemos dos preguntas del público, lo cual agradezco que se estén haciendo preguntas. Una es del doctor Jorge Bernal y dice, hola, buen día, felicidades por las pláticas. Durante la pandemia, ¿la extensión de la cirugía oncológica debe ser la misma o hay que limitar la extensión de la cirugía oncológica? Quiero pensar que se refiere a la radicalidad.
Any one of you.
If I understand the question, how radical? Oh, go ahead. I would say we're probably trying to be more conservative than radical.
Voy a volver a hacer la pregunta. A mí tampoco.
Creo que la pregunta se refiere un poco a la radicalidad de los procedimientos conllevan a una duración de la cirugía mayor. Sí deberíamos a lo mejor limitar la cirugía a procedimientos más cortos en el quirófano, ¿no? Creo que es en este tiempo de pandemia.
I think so. I'll try to tackle it first, maybe. A lot of that really just depends on the resources that your facility has in the context of how prevalent COVID is in your community. There were times when we had very high numbers of COVID positive patients in the hospital and our ICUs were at maximally occupied, that we did have to restrict critical cases. And sometimes it's not always the cancer cases that are the ones that are being restricted. Sometimes it might be transplantation or heart bypass operations that may get put on hold to allow you to do the bigger cancer operation, you know, if you feel that it needs to be done. But I think it's really a resource thing. I don't think we've so much had a change in the specific nature of an operation related to the pandemic. I think more what we've seen is just what is the optimal timing of that intervention in relationship to the prevalence of the infection in your community and the hospital resources that are available.
I mean, I could see that if resources were significantly limited, like Doug was saying, where you really didn't have a lot of functioning ORs and you're using some for ventilation of patients and so forth, that you really are going to have to triage things significantly in cases where the prognosis is dismal, that are going to take a long time. Maybe we would get to a place where those operations should be limited. I don't think we're there right now. We've been fortunate to be able to go back to almost business as usual for the time being. But certainly if we were in a situation like New York and that were to persist for a while, then you would be just doing whatever was emergent. And if you had a big backlog of cases, you might need to triage them to the ones that you could get done more expeditiously to use your available OR time. So I could see that happening, but it hasn't really happened yet.
At MD Anderson, we're really back in business, including in elective cases. Interestingly, in order to catch up and also to space out things and to clean the rooms, we're operating 7 days a week now instead of our usual 5 days a week. But the SSO and the American College of Surgeons on their websites have some very nice resources that list the way to prioritize specific diseases in specific cases. So that, as was said previously by Dr. Howe, is each hospital should have a triage system with people from the ICU, from anesthesia, from the surgery chiefs, who can actually adjudicate and triage and prioritize patients depending upon the actual timing of the need for their surgery and the capacity within their hospital, especially ICU capacity and blood capacity as well.
Muchísimas gracias y muchas gracias, profesor Balch, profesor Howie, profesor Douglas Taylor. Gracias, Héctor. Creo que muestra perfectamente hoy la adaptabilidad que tenemos los cirujanos oncólogos en estas condiciones, incluso de crisis, en compartir. Muchas gracias por cada una de sus experiencias, por cada uno de los momentos que hemos pasado, tanto en vivo como ahora híbrido. Gracias.
Y nada más recordarles al público que esta sesión va a estar on demand, ya de forma completa, incluyendo la participación del doctor Domenico de Hugo. Y para la tarde ya podrán estarla viendo y gozando las veces que ustedes quieran. Muchas gracias y muchas gracias por esta asociación tan exitosa entre SMeO y SSO y la European Society of Surgical Oncology. Muchas gracias.